Hi, everyone. Thank you so much for coming today. So, as you know, it's our pleasure to have you with us. And yeah, this is our second year having the Neonatology Cardiology Research Day. And we are hoping to have you here next year as well. So, to start, we're going to have Dr. Otit give some words. And then we're going to have Sabrina Burns from the foundation. Thank you so much. And also, feel free to eat as much as you want.
Okay, perfect. Thank you, everyone. So there's going to be for sure more people trickling in to the room as we go along for this day. So it's really a pleasure to have you all join us for this second half day of neonatal cardiovascular sciences. And we have really a wonderful roster of speakers. We have Dr. Tiscar Cavalle Garrido, Dr. Frederic Dallaire, and Dr. Nagib Dahdah, who are all going to be our keynote speakers. They're wonderful pediatric cardiologists, and we'll tell a bit more of their bio when it's time for their presentation. But I can say that they all have been mentors as part of my own journey, and they are brilliant, both clinicians, researchers, scientists, and will share a bit of their own journey, knowledge, science, expertise to our group. So before we go on with the day, first of all, I do want to thank Mallinckrodt Pharmaceuticals, who provided an unrestricted fund so that we can host this research half day and really share together knowledge and science. I do want to also thank our organizing committee, which includes Daniela Villegas Martinez, the project manager of the NeoCardioLab, who worked very hard to make this day a reality. Our speakers, some of which have come from far to share their knowledge. Miss Leila Wazne, one of our neonatal nurse practitioner in the NICU at the Montreal Children, who has a strong interest in cardiovascular science, who will be working as a judge also today for some of the abstracts being presented. And of course, all the members of our NICU cardiology division, our Montreal Children Foundation, who will be giving a few words, the CHHD, the Research Institute. And I do want to do a special mention for the team of the Shriner, who is providing us with the venue today and the support in terms of IT so that we can have this day going on. So Daniela, did I forget anything? Very good. I'm on a good track. So I'm posting here, and this QR code will appear a few times today. But the QR code will bring you to the page in order to provide the feedback form. We do use the feedback so that we're able to tailor next year's content of this presentation. So we're going to be very happy to read your feedback. And so please take the time. It takes only 2 minutes to answer the form. It's also available through the page of the website, which includes also all the abstracts and the information for the day. So we're going to have a few minutes now for the Montreal Children Foundation to give a few words. The Montreal Children Foundation has been instrumental to support the NICU, the cardiovascular sciences at the Montreal Children's Hospital. And so they're always very strong partners for both the clinical care we give, the research, the science, and the education at the MUHC and the Montreal Children's Hospital. So we have Sabrina with us from the MCH Foundation to give a few words.
Hi, I just wanted to start. Hi, my name is Sabrina, and I'm with the Montreal Children's Hospital Foundation. I have to start by saying how excited I am to be here today. It's always inspiring to step into a space where research and care truly comes together. I'm the special events team, and I had the pleasure to work with Daniela while organizing the event Salted to Life. It's an event for young professionals supporting extraordinary talent, just like everybody in this room at the hospital. At the Children's Foundation, we have the privilege of sharing the incredible work happening in the hospital with donors and community partners who wants to make a difference. But what's most meaningful for us are moments like this, where we get to hear directly from the people doing the research, driving the innovation, and changing lives every day. Your research not only improves outcomes today, but builds the knowledge that will transform care for generations to come. Thank you again for your time and for the extraordinary work you do for the patients and families coming through the children's. It's an honor to learn from you and to help connect your vision with the people who want to make it happen. Thank you.
Thank you, Sabrina, and thank you for all the work that the MCH Foundation is doing. So we're going to be organizing. We just need to stop share and then get the presentation of Dr. Cavalle. So we're going to start with our agenda of the day with the invited speakers. Our first speaker is Dr. Tiscar Cavalle Garrido. I just want to say that Dr. Tiscar is amazing before I give the bio. Dr. Tiscar Cavalle Garrido is significantly involved in the Department of Pediatrics at the Munch Children's Hospital. She's acting as the director of both the Pediatric Cardiology Training Program and the Pediatric Advanced Imaging Fellowship Program. She's one also of our lead in our neonatal hemodynamics program at McGill University. She completed her university and medical degrees at the University of Valencia in Spain and completed residency in pediatric cardiology, echocardiography, and as well some years of research at Sick Kids in Toronto. And then she joined our group at the Montreal Children's Hospital. She's one of the national leader in pediatric and fetal echocardiography, and she's one of our leader at the fetal treatment diagnostic group. She also has a strong interest in aortopathies, and today she'll be speaking a bit on fetal cardiovascular medicine and physiology. So it's a huge pleasure to have Dr. Cavalle, who's been a mentor throughout all these years, who will be presenting on fetal cardiovascular physiology.
So good afternoon, and thank you so much for the kind introduction and for the opportunity to present to you today. I feel a little bit like I'm in NeoCardio monthly rounds, like I feel at home, so it's great to be here, and welcome to everyone. So I'm just going to be talking of the fundamentals of cardiovascular physiology in the fetus, which is very close to the neonates, obviously, and to just mention the method that we use for assessment in a non-invasive manner of the cardiovascular physiology and physiopathology of the fetus, and then provide some examples. So I don't have any disclosure. So objectives: understand the fetal parallel circulation and specify the three shunts that make that happen in the fetus, to understand the unique characteristics of the hemodynamics and the oxygen delivery in the fetus. And as I said, become familiar with non-invasive methods that we use both in clinical practice, but also in research. So the fetal circulation is different, as you all know, from the postnatal circulation, because the postnatal circulation is serious and the fetal is a parallel circulation. Also, the gas exchange happens in the placenta, not in the lungs, right? The lungs are not functioning. The pulmonary vascular resistance is very high in the fetus. The lungs are not functioning, they're full of fluid. Whereas the systemic vascular resistance, which in the postnatal life is much higher than the pulmonary, is actually low in the fetus because the fetal circulation is connected to the placenta, which is a very low resistance circuit. Also, the most oxygenated blood in the fetus goes to the precious organs, the heart and the brain. And no offense to anybody that doesn't do neurology or cardiology. And this is facilitated because of the presence of these three shunts. There's one extracardiac and two intracardiac. That allow for preferential streaming of the blood, and we will see that. So it really is a shunt-dependent circulation. So I think everybody knows the fetal circulation, right? The blood comes from the placenta, rich in oxygen, just oxygenated through the umbilical cord into the baby, umbilical vein, and when it gets to the liver, the blood actually gets directly, half of it through the ductus venosus into the right atrial IVC junction, and then actually part of this blood also goes to the portal vein system and through the hepatic veins back to the heart. So it's not just a straight tube, there's a little bit of a complication there. we know that this blood that comes from the umbilical vein through the ductus arteriosus is going to go across the foramen ovale, and we'll explain why that happens. So that the rich in oxygen blood is going to go to the left heart, ejected through the ascending aorta. So this oxygenated blood is going to be preferentially to the coronary arteries to feed the fetal myocardium, and then to the brain. What happens on the left side and on the right side of the heart? Well, we have the blood from the inferior vena cava, which is very desaturated, the blood from the superior vena cava that mixes in the right atrium and kind of flows into the right ventricle, pulmonary artery. A small amount goes to the pulmonary artery branches, and then most of it is going to shunt through the ductus arteriosus to the descending aorta. So we already mentioned the three shunts: the ductus venosus, the foramen ovale, and the ductus arteriosus. So we're going to focus on the ductus venosus. So it's you see this picture here. So sorry for the people that are over there, but essentially you have your left umbilical vein, and then it connects to the ductus venosus, which is a trumpet-like or funnel-like shape. And the purpose of this shape is to cause flow acceleration as the diameter gets narrowed, so that when the blood gets into the right atrium, it's actually a jet of high velocity. But as you can see, and as mentioned before, part of this blood also goes to the portal circulation and through the hepatic veins into the right atrial IVC junction. So I have to mention that actually in the liver, there's not a lot of oxygen extraction. So the blood that returns to the right atrium via the hepatic veins is still quite saturated. So it's still rich in oxygen. So that explains some the saturations that we see globally in the circulatory system when I show you. So there's mixing, a little bit of mixing of blood everywhere. So one important thing to know is that in situations of hypoxia, the ductus venosus will dilate, so it will direct more oxygenated blood directly to the heart and less to the liver. The second shunt in this duct is the foramen ovale. So just to orient you here, this is the head of the baby, this is the feet, the fetus, this is the back, and this is the front. So we're really looking at the fetus from the right side. And so here we have two venous channels that we already hinted before: the inferior vena cava that brings not very oxygenated blood to the heart, and the ductus venosus that brings oxygen-rich blood to the heart. So you can see this little line here is the flap of the foramen ovale. This is the left atrium, which is more posterior than the right atrium in the heart. And you can see that this blood is coming from the ductus venosus high speed. It's gonna push this flap that should be, aligned with the rest of the interatrial septum, pushes it open, and that's how this oxygenated blood makes it into the left atrium preferentially. And the inferior vena cava plus the superior vena cava flow will kind of flow at a lower velocity into the right atrium and will be directed to the right ventricle. But you can also see these little arrows here. So some blue blood will make it to the left atrium, and some pink blood will also make it to the right atrium. Should I be closer? Sorry. Okay. So you can see then that if there's changes in the normal pressures between the left atrium and the right atrium, that these shunts will be altered, and that would affect oxygenation and preload. So this is a little echo clip of how we see actually these shunts in the echo lab every day when we look at fetuses. And let me see how that's gonna click. I guess I'll click this way. Play. Oops, it's not displaying. Okay, sorry, it's not playing the computer. So I think the lights are a little bit bright. But essentially, here you have the inferior vena cava. This is the superior vena cava. The superior, we have the baby. Obviously, this is the spine. This is the belly of the baby. The head is here. The feet are there. This is the diaphragm. These are the lungs. And this is the liver. And you can see this structure here, that's a black structure. It's actually the umbilical vein that is coming to become the ductus venosus at the IVC right atrial junction. You can see this flap here. This is actually the eustachian valve that helps direct the flow of the ductus venosus. And as I mentioned before, the right atrium is anterior, the left atrium is posterior. And you can see this little white flap here that is actually the flap of the foramen ovale. So you can imagine the blood coming from the umbilical vein, ductus venosus, kind of directed a little bit by the eustachian valve, and then going at high velocity, hitting the foramen ovale flap and getting into the left atrium. And you can see that also by color Doppler. I'll stop this one to play. I'll stop the other one and see if this one plays. Oh. Should be playing now. Okay, perfect. Thank you for your patience. So this is the same idea, the same image, but now with color Doppler. So here you have a hepatic vein that see the dark blue indicates that it's low velocity compared with this much brighter blue that indicates that it's high velocity. And you can see the orientation of this jet going boom all the way back to the left atrium. So these are things that when I was a medical student, people try to explain to me what do you mean the one flow decides to go to the right and the left? How does that happen? So when I started doing fetal echo, I'm like, oh my God, of course, I understand clearly now. So the third shunt is the ductus arteriosus that, as you know, connects the main pulmonary artery with the descending aorta. And here you can see, so you're all familiar with this anatomy of the fetal heart. This is the main pulmonary artery, and you can see that actually in the fetus, the main pulmonary artery trifurcates. It doesn't bifurcate in the left and right pulmonary arteries. It trifurcates because there's another branch that is the ductus arteriosus. And in fact, even most diagrams, is interesting that they make the pulmonary arteries bigger or similar to the ductus arteriosus when we know that when we look at the fetus, actually it's much bigger. And also to note that it usually connects just at or distal to the left subclavian, so a little bit more that way. And essentially what the ductus venosus, ductus arteriosus role is to bypass, as we said before, these non-functioning lungs and to bring the blood to the lower body. So the ductus arteriosus is a very important structure for us in neonatology and cardiology because the patency of the ductus arteriosus after birth may be critical to maintain a baby alive if the baby has cardiac malformation with left or right-sided obstruction. So if you have a left-sided obstruction, the blood that's flowing from the pulmonary artery normally after birth will actually go through the ductus venosus down the aorta and provide blood flow both distally, but also retrograde to the ascending aorta, coronaries, head and neck vessels if you have, let's say, critical aortic stenosis, and the opposite is the case when you have severe critical pulmonary stenosis, pulmonary atresia. The ductus venosus flow, arteriosus flow from the aorta to the pulmonary artery will maintain pulmonary blood flow, will keep the baby alive until we're able to do an intervention. And this is another clip of the ductus venosus arteriosus as we see it in fetal life. So again, I hope you see this well, but essentially what we're here and see is an image similar to the one that I showed before, but a little bit tilted toward the left of the baby. And here we can see the aortic arch, but you can also see the ductus arteriosus. We're flipping from one side to the other. I think it's a little bit bright, but what I was hoping to show you is that we see the pulmonary artery trifurcating, right pulmonary artery, left, and ductus arteriosus, and that here, this is the area of the isthmus where the ductus arteriosus and the descending aorta meet here at the isthmus, and then the flow goes down to the rest of the baby's body. So with all of that, so where are the saturations in the fetal heart? So as we mentioned before, the most saturated blood is in the umbilical vein, just with blood freshly oxygenated in the placenta. And the lowest is in the inferior vena cava. So you can have in the umbilical vein a saturation of 70, 80, 90%, depending what you read and depending whether it's human or fetal literature, fetal lamb literature. The inferior vena cava saturation 35%. And then, as we said before, so the IVC and IVC flow go to preferentially to the right atrium, and the umbilical vein flow to the left atrium across the foramen. So if you look at this IV, the umbilical vein, the saturation, as I said, around 80%. In the ascending aorta is 65. Why? Because of the shunts that we talked before. Not all the super oxygenated blood goes only to the LAs. There's some mixing from the right side. And the pulmonary artery saturation is around 55%. Why is it? Since the IVC and the SVC are low, because there's some mixing. Okay. So finally, the saturation in the descending aorta is a little bit lower than the ascending, because it's receiving blood from the PDA, and is around 60%. So the role really of the fetal circulation is to oxygenate the fetus the most efficient way. So there's two things that influence the oxygen delivery to the baby. One is the oxygen content in the fetal blood, and the other one is the cardiac output. So the fetal blood actually is very rich, as everybody knows, in fetal hemoglobin, which has a very, very high affinity for oxygen. And what it does is that for that reason, it has the capacity to extract a lot of oxygen from the placenta. And so for a similar partial pressure of oxygen, you see that the saturation in the umbilical vein is higher than the uterine veins. In terms of cardiac output, in the fetal circulation, we don't talk about just cardiac output, we talk about combined cardiac output, because unlike the postnatal circulation, the right ventricle and the left ventricle don't eject the same amount of blood because of the circulation being in parallel, not in series. So LV and RV have different volumes, have different stroke volumes, but they're still interdependent, okay, with usually the right ventricle having a higher right stroke volume than the left. Also, it's important to know that 45% of the combined cardiac output, both in left and right cardiac outputs, goes to the placenta, and a very, very little amount to the pulmonary circulation. Again, that's because the lungs are not working. So what determines cardiac output in the fetal heart and any other heart? Preload, afterload, contractility, and heart rate, we learn in medical school. And you know that the stroke volume times the heart rate is what constitutes the cardiac output. In the fetus, the normal combined cardiac output is around half a liter per minute per kilo of weight. So in terms of preload, the fetal blood volume is actually 10 to 20% of the baby's body weight. So it's higher than in the postnatal life and in the adult. Take into account the large blood pool in the placenta. And because of that large blood pool in the placenta, the fetus is capable of very fast regulation and restoration of blood volume because the diffusion in between compartments. In terms of afterload of resistance, as we said before, we have a low SVR in the fetus, a high SVR in the high PVR. Sorry, this is not for us, right? The blood pressure in the fetus increases throughout gestation, and you can see that at 16 weeks, you have a blood pressure around 20 millimeters of mercury, and by 28 weeks, it's almost doubled. Also, the diastolic pressure increases quite a bit, doubles or triples throughout pregnancy, but with no difference between the ventricles. The pulmonary venous pressure also increases as well. What do we know about the fetal contractility of the myocardium, which is another factor that influences cardiac output? So first of all, the fetal myocardium grows by hyperplasia. The fetal cardiomyocytes divide, unlike the postnatal cardiomyocytes that they only hypertrophy, they get bigger. The fetal heart has a greater content of water than postnatally, and a reduced myofibrillar density, which means you have less contractile elements in the fetal heart. So 30% in the fetal heart versus 60% in the adult heart. So that causes some degree of impaired myocardial contractility if you compare with the adult. And on top of that, because of the immature handling of calcium, because of immature functioning of the sarcoplasmic reticulum and greater dependence to certain ionic pumps to metabolize the calcium, that results in impaired myocardial relaxation, which if you add to that the fact that the baby's body is surrounded by fluid, and the maternal abdomen. There's a lot of factors that can also cause restriction. If you compare to a normal heart that's surrounded by air in the lungs, air outside the body. So that puts the fetal myocardium in a precarious situation compared to the adult. And so the consequence of that is that the fetal stroke volume is relatively fixed. And so to change the cardiac output, to increase the cardiac output, really the babies depend on fetal heart rate. How are we doing the time, Gabi? Okay. So the next thing I want to talk to you is about the Frank-Starling law. We also learn in medical school, right? And what it tells us is that as we increase the end diastolic volume in the heart, we stretch the myocytes, then the myocytes contract back. And so you can increase your stroke volume by increasing the preload of the heart. The fetal heart is actually very different from the adult heart. And if you see here in this graph, oops, that was fast. If you see here, this is the experiment with fetal lambs. So this is the fetal lamb, this is the adult. This is the stroke volume, and this is the atrial pressure, which is a surrogate for preload. So the more preload you have in the right atrium, the higher the pressure will go. So in a mature heart, you can see that as the pressure goes up, the stroke volume goes up until you reach a breaking point, which is, as you can see here, around 16 millimeters of mercury, something like that. If you compare that with the fetal heart, whereas by 4 to 5 millimeters of mercury, you reach the breaking point of the Frank-Starling law, it really is very striking. It tells you how limited the response of the fetal cardiac output and stroke volume is with regards to preload. So again, limited ability to increase stroke volume response to increased preload, myocardial stiffness, and impaired relaxation. And then the external constraints that I referred to before makes the heart rate the main mechanism to augment cardiac output in the fetus. Let's talk a little bit about the combined cardiac output, right ventricle versus left ventricle. So as I hinted before, the right ventricle delivers around a little bit less 2/3 of the combined cardiac output. So right ventricle, main pulmonary artery, ducts, arteriosus, descending aorta, lower body in placenta. As I said, a very small percentage of blood goes to the constricted pulmonary arteries, and it carries a relatively low oxygenated blood from the caval and hepatic veins. Whereas the left ventricle delivers a little bit more than 1/3 of the combined cardiac output from the left ventricle to the coronary circulation to the head and neck vessels, and a little amount into the descending aorta to the lower body. And this is, as we said, is relatively higher oxygenated blood, mainly from the ductus venosus. So essentially, the right ventricular volume is higher than the left. However, because the pressures are the same, as I mentioned before, they are exposed to the same afterload, they have the same thickness. So here is a short axis view of a fetus, of a fetal heart, and you can see this is the spine, this is the front, this is the anterior ventricle, so the right ventricle, and this is the left ventricle, the posterior ventricle. You can probably realize by now that the heart is not left and right only, the structures are also anterior and posterior. So as you can see there, the right ventricle is larger than the left, but the thickness of the walls are the same, which is very different from postnatal life, as we know that when the vascular resistance in the lung goes down, the pressure in the right ventricle goes down, and the wall of the RV becomes much thinner. The other thing that is interesting to see here is that you can see the wall in between the two ventricles is flat. That means that the pressures at both sides are the same, because if it had a curved shape, that would mean that in one ventricle the pressure is higher than other, usually the left ventricle, as we see postnatally. So the reason I'm showing you this is because then the last consideration is the concept of ventricular wall stress, that is driven by the Laplace law. And essentially what it says is that wall stress, the stress of the walls of a vessel or a chamber, are directly proportional to the radius, so how big is it, and the transmural pressure, and inversely proportional to the wall thickness. So if we think of the left ventricle and the right ventricle, I just said that the thickness of the chambers, the wall chambers, is equal in both, but we know that the right ventricle is larger. So then that means that the wall stress will be higher in the right ventricle and the left, which means that the right ventricle is more sensitive to preload and afterload changes, and that in pathological conditions, you will see ventricular hypertrophy, ventricular dilatation, or ventricular dysfunction earlier in the right ventricle than the left. So how does this all get regulated? So first of all, heart rate control, which matures throughout fetal life. There's also, as we all know, baroreceptors, chemoreceptors, catecholamines, vasopressive, atrial natriuretic peptide that control blood pressure and homeostasis. And of course, the placenta acts as a huge regulator because it has this pool of blood there that can move quickly to help with maintaining hemostasis. And a very important feature of the fetal circulatory regulation is the brain sparing effects. So when there's fetal distress, there's mechanisms in the fetal circulation to protect the vital organs, the heart and the brain. And so what happens in these conditions of hypoxia, there will be vasodilatation of the coronary arteries, of the fetal cerebral arteries, so that flow will preferentially go there, and vasoconstriction of the other organs, so that the pool of blood that is available is going to go to those vital organs. Vascular fetal physiology was in fetal in animal models, usually fetal lambs, and with very invasive techniques that included catheterizing and putting catheters and measure pressures in these animals. But since the advent of fetal echocardiography, things have changed because this is a very readily available tool that we use in clinical practice, and it has multiple research applications and has helped us understand very well how the heart works in the fetus. So apart from being a very important tool for the detection of congenital heart anomalies, which Dr. Dallaire will talk later about, it helps us know how the heart works. And it's really the cornerstone of all the tools that we have to analyze fetal cardiovascular physiology at this time. There's also fetal MRI that is actually advanced a lot in the study of fetal cardiovascular physiology, and won't get into this, it's a whole other topic. The importance of cardiac fetal MRI is that actually MRI can measure oxygen levels because this oxygenated hemoglobin has a special signal that MRI can analyze and tell us what the oxygen levels are non-invasively in the fetus, which is quite remarkable. There's other tools like fetal magnetocardiography and fetal electrocardiography that can be used to study the fetal heart rate and rhythm, which are usually research tools, although in some centers there's some clinical application. There's a lot of work being done on maternal hyperoxygenation. If I have time, I will mention a few things at the end of the talk. And then there's emerging modalities, including AI, that I will just mention here. So with fetal echo, we're able to do a lot of things. So the fetal echo has, fetal cardiac ultrasound has different modalities. We have two-dimensional 2D echo that helps us assess cardiac anatomy, chamber size, valve motion. M-mode looks at motion of chambers over time and is useful for assessment of ventricular dysfunction and help with cardiac rhythm, although it's not the best for cardiac rhythm, it's helpful. Doppler ultrasound is all of what I'm going to talk for the rest of the presentation. It's a super valuable tool, helps us evaluate flow direction, flow velocity, impedance, and intracardiac flows, and key vessels such as the ductus venosus, the foramen, the ductus arteriosus and also the umbilical and cerebral arteries. And also that Doppler ultrasound is critical for diagnosis of fetal arrhythmias. Finally, tissue Doppler and speckle tracking echo are being used. Tissue Doppler is helpful with function and also helpful with fetal arrhythmias, but there's is a little bit involved in terms of post-processing, so we don't use it in daily routine. And also, you can use strain rate in the ventricles, in the atrium, and this research in these areas is actually giving some additional insights in how the fetal heart works. Finally, 3D and 4D volumes can be also used, but at present is mainly investigational. So what do we do? What do we look at on in the fetal heart on a daily basis when we see an echo? We do a fetal echo. We look at tricuspid and mitral valve inflow, ductus venosus, ductus arteriosus, aortic isthmus, MCA or middle cerebral artery, the umbilical vein, the pulmonary veins, and then we assess rhythm. So these are the things that we assess routinely on a fetal echocardiogram, but that are very useful for research as well. So this is an example of the flow through the mitral and tricuspid valve. So this, I think if you look at your cursor, this is the four-chamber view, right atrium, right ventricle, left atrium, left ventricle. This is the tricuspid valve, so we're measuring the velocity. And on the other side here, we're on the mitral side. So you can see here's the transducer. So the blood going through the mitral valve and tricuspid is positive flow going to the transducer. And you can see that this is like spiky kind of M-shaped pattern. The first pattern is what we
to ultrasounds?
Yeah, I think that 2 is enough for the vast majority, because if we look at the sensitivity of echo to detect a CHD by a cardiologist, it's above 90%. So it means that the echo machine and the ultrasound technology is enough to detect it. It's the person that reads the images that makes the difference. So we need to work on that second trimester ultrasound, where most of the CHD, critical CHD, will be apparent. Not all of them, but adding another one, I don't think we would increase a lot, and we would detect them much later in the pregnancy. So this creates problem, right? So we'd like to know at 20 weeks of gestation. If we know at 32, that's lots of complication around. So I think we're doing this exam on every single pregnant woman at the second trimester. We should work on that exam and how we interpret these images.
Okay, thank you very much.
I find it's really cool, the dashboard. I'm going to be honest. I hope that's the venue of the future, but not just for congenital heart, because we do a lot of fetal work, but I think for many of the malformations that we see or conditions we see in fetal life, having light feedback. I mean, your research is great because I think that's going to show, institutions and provinces and many jurisdictions of how to actually instantaneously feedback to centers of what areas they actually need to be improved. And I hope that this can be applied not just for the heart, but for actually many of these conditions that we try to pick up in fetal life. I think one thing we don't realize is that our obstetrician radiologists and all of these perinatal professionals, they have to screen for so many things, and the heart being one very important entity. And we're here today for the heart, but there's obviously so many of these conditions. So hopefully they can use some of that dashboard philosophy and technology and apply it to all of these other things so we can continuously improve ourselves for the care of these pregnancies. Thank you so much, Dr. Dallaire. That was great. Okay, it's my pleasure to have our last invited speaker before the break. We have Dr. Nagib Dahdah with us today. Dr. Nagib Dahdah is a pediatric cardiologist and researcher at CHU Saint-Justine. He focuses on studying Kawasaki disease and the axis between metabolic and cardiovascular health. Dr. Dahdah is also an expert in cardiac catheterization. He completed his medical studies at Saint Joseph University in Beirut, Lebanon. His training in pediatrics and pediatric cardiology spans several countries, including Lebanon, France, the United States, and Canada. Dr. Dahdah founded the Kawasaki Arab Initiative, a nonprofit organization which focuses on improving the health of Kawasaki disease in the Arab world, and he's one of the world leaders, actually, in Kawasaki disease and has chaired many of the conferences regarding this. So thank you so much, Dr. Dahdah, for coming here and presenting with us today.
Excellent. Okay, cool. Can you hear me well? Yeah, otherwise I'll scream. So good. Please, if you have questions during presentation, stop me. They'll be helpful. I'll feel empowered that you're interested in my talk to start with. Don't feel ashamed if you think the question is too silly. There's no silly questions. Only my answers would be silly. Okay? Voila. So, merci. First of all, I would like to thank the preparation of this excellent program, not just today's, but the program of NeoCardioLab. I was impressed with that when I first heard about it on LinkedIn a couple of years ago. And I'm so proud that I'm invited and that you did this program, because besides doing research and being impactful in research, what is more important is to have a research program where new leaders will start from this lab and go and become leaders elsewhere. So congratulations. One of the other things I would like to thank is Frederic. Frederic worked together 3 years ago when we were young in one of our first papers, and became like a important paper for Kawasaki disease, diagnosis of coronary artery aneurysm and classification of them. And this is another pride I would like to share with you, that as you just understood, Frederic is not just a researcher. He's built a program within Canada and the US
bringing people together. And now he's built also another program of very interesting research for Kawasaki disease and the coronary artery dimensions. It's a worldwide program, joining many people who are really top people, aces in coronary artery normalization in Z scores to make it more global and more representative of what we need to use as a single or one streamline of identifying coronary artery problems in Kawasaki disease. Tiscar, thank you very much. Your presentation was excellent. I did not even sleep a second. Very well. So yeah, Kawasaki disease is my big thing, but also intervention is another big thing to me. I stopped doing catheterization just 1 or 2 years ago because I shifted in my practice, more focus on KD. But this is very interesting point, the PDA in preemies and PDA in general, because things have shifted and things have been a little bit different. So here's just introduction. You won't read every single slide. There's no reading. But I'd like to point out something that's very important to keep in mind. This is why this text is here. I'm going to read it for you, and please remind yourself of this. So after birth, the ductus arteriosus undergoes physiological dynamic closure with a prostaglandin receptor mechanism. Due to an underdevelopment of the prostaglandin receptor cells in the ductal tissue of the premature born baby, the PDA is more prevalent in the preemies compared to children born full term. This is not the only thing in preemies, but there's something else to it. Now, in the last few decades, the sharp increase in survival rate of the extreme preemies, thanks to people like neonatologists in Montreal, it led to increased proportion of a persistent PDA in addition to being in atypical anatomical shapes. We'll see about that in a second. Now, the other point I'm going to address is the occlusion devices that we use in the cath lab. They were initially developed for typical conical shape PDA. I'm going to show you what is a typical conical shape PDA. They are neither adapted nor designed for the elongated tubular PDA of the preemie. So this is another problem, okay? These are statements. Now, therefore, inherent risk of unsuitability of currently available PDA devices, including those adapted to tubular-shaped PDA for the preemie, causing potential complications and the possible hemodynamic repercussion of device protrusion into the aorta and towards the left coronary artery. This is one or some of these small problems. So I'm not going to talk today to brag about how good we are. I'm going to talk about how many failures we could have. Okay, so calculating the risk that Frederic just told us, are we way below or way above on the risks? It is not to tell you what we as interventionists in Montreal or elsewhere we do, but to see what is the big picture. Because PDAs are very important physiologies in your patients, in the neonatology patients, but we see also these patients down the road, several months, few years after birth, and they still have this PDA. So these are the kind of devices we use. In the past, probably 20 or 15 years ago, we used to use coils. These coils are just small filaments made of metal. They are very useful in small ductus arteriosus, but useless in large PDAs. Why? Because they just fly away in the lung or sometimes in the legs. So it's a little bit out of use nowadays. One of the first very good devices is the Amplatzer duct occluder. This is the shape of it. And then they created this one, which we call the type 2 occluder, but this one fell down because it didn't work like we're supposed to work. These discs on the right and left side, they're supposed to capture the ductus teres like that. What happens? They just flip out or they punch like that. So technically, it was very, very well thought of, but practically, it doesn't work well. So they shifted to what they call ADO to additional size. This is a way that companies cheat the system, okay? So because it's completely different device compared to this one, they had to go through FDA with filing and years and trials. They said, it's the same thing, just additional size, which is not the case, but still works. And then we have plugs. Plugs are also metal filaments. They are very flexible. We push them in tube with the catheters. We put them in vessels we need to close down. They're not supposed to be used in the PDA, but we cheat the system. As I said, many of these devices are not suitable or made for PDA closure, but we still use them because we have to, okay? This is another company that does this kind of device. It's the Occlutech company. It looks like this one. It's shaped a little bit differently. It's longer and larger and so forth. So now that you understand all the technology about PDA devices, we're going to talk about the anatomy. So the typical ductus arteriosus, this is the aorta, descending aorta, this is the pulmonary artery, all right? The typical ductus arteriosus is conical in shape, okay? It's large at the aorta, it's narrow at the PA. So if we ought to put a device to close it, because this is higher pressure, we'll put a device here. It will be stenting itself inside this neck, the waist here, in a way that doesn't move to one side or the other. It's stable, it's safe, it's good. This is very rare. It looks like a window. It has nearly no waist, and it's rare, good enough. Now, the babies who were born prematurely, they don't have this kind of conical shape, PDA. They're like a tube, okay? Just like a sausage, like that. So there's no waste. We need to have a way to put something inside that's stable enough and doesn't float inside the PA to the lungs or down to the legs. It's very important. Stability is very important, right? Otherwise, it's a niche for complications. Now, another type of creamy PDA is like this one. It's really elongated, but it still has some sort of neck, narrow neck, or tortuosity. This one is much more tortuous. It's as rare as this one, but it's useful to close and it's feasible to close. This is what we see on the angiography. Can you see that? This is what we see on the angiography on the cath lab. This is the aorta. Just injected here a dye. You can see the descending aorta like this one. You can see the conical shape and the narrowing. This narrowing is not always the same size. It's small, medium, large millimeters, and therefore we have to decide on what size of PDA device we need to use. Make sure it's stable and not too much, not too big. Otherwise, it will be bulging way too inside there or inside there. And this is what the premium would have. It's an elongated, straightforward PDA. It doesn't look at all like this one. And therefore, if I use a usual PDA device, it may go this way or that way. So also decision making of the size of the device is different. Decision making of the type of device is also not the same. There's too much light, but I'll try to explain and you try to see with me. So this is a conical PDA, and this is where the device is sitting here. Can you see with me, or if you cannot, just let me know. So this is the device. It has shut down the PDA, and now when we inject the dye, there's no shunt from here to there. Except that sometimes we use the same device in a patient where we can see that there is a protrusion towards the aorta. So this could be a problem because it will create turbulence here. It could create also high pressure, almost like if a child has a secondary palpitation. Okay, so the device is good to close the eye, but it could be bad for the aorta in terms of building pressure. Again, if you have questions, please stop me. Now, here's what's good about neonatology is survival rate of even very small preemies, very young gestational age. This is general international data. We see that babies born 22 weeks gestation, survival rate has increased from 7% to 30% in these years. Those are 23 years, only 1 week older of gestational age, from 32 to 58 or 56%. Now in Canada, apparently it's 70.9% survival rate for infants born 23 to 32 weeks in 2018, compared to 56 15 years or 14 years earlier. Why is that? This is because there's a shift of anatomy, shift of proportions of babies and children with PDA. So for us in the cath lab, also for surgeons, it is different kind of patients, different kind of approach. we cannot say that we can deal with it because it is a PDA. It is a PDA, it's not the same shape, it's not the same thing, and the babies are not the same, they're much tinier, much smaller, and the risks are increased, right? So one more time, just to refresh, if you see here, this is descending aorta, this is the PDA. Just notice that the PDA in this baby is as big as descending aorta. So if you leave this baby without closing it, while in neonatal care, there's a high risk of big shunt and big heart failure in this kid, as well as increased flow to the lungs, which would lead potentially to hypertension and so forth. So this is very, it's like the full aorta is being, is flooding the lungs. There you go. See, these are different examples, as you can see here. So a study that we did, we're gonna publish this, I hope sometime soon. It's ready to be submitted in a week or two. We looked at the last 206 cases at NGC, went to the cath lab. What I would like you to notice here is the anatomical distribution of the ductus arteriosus according to prematurity. Okay, so this is the Chenko series is a series where we describe shapes and types of PDAs back in the 1980s. So the highest proportion is about 64% for type A, and then less type B. Type B is what we see now in the previous, okay? So in our series, this is what we have seen. There's a shift to the right of these types of PDAs. In other words, we have much less than in the 80s in terms of type A or the conical shape PDA, whereas we have much higher type B, type C, and B, okay? In the non-previous, for instance, in the same series, our series of 206 babies, those who are not premature babies, 51% had type A, which is very much like in the 1980s. And now in the subgroup of previous, only have 70%, and the rest of these kids have type C or type B PDAs. Why is this important one more time? Because nowadays we cannot just have our cath lab full with tubular shaped PDA devices. It doesn't work because much higher proportion of our kids have type C and E, have type preemie PDAs. So we need to be equipped. If you ask the hospital, well, we need more money for these devices, they're going to ask you why. We have to tell them because we have different kind of population we have to deal with, right? So because we cannot re-engineer the patient force themselves on us, we have to re-engineer the way we deal with these PDAs. Procedure itself is still easy and simple. Now look at this. This is what we used to do, and we have these type 2 additional size, which is called now Piccolo. Okay, the Piccolo is this device. It's very tiny, and it was the ADO2 additional size. It was named Piccolo one more time because in the US, they were not allowed to use this device until they ran a big trial. But in Canada, we used to use it because we were allowed to. So when it was approved by the FDA, they gave it a nice name. It resonates very well. It sells very well. Okay, so branding is important. So now we use this Piccolo for these babies, but is it good enough? Let's see. Of course, it's good enough because it works. So the shifting anatomy of PDA towards a new paradigm for unmet needs. Okay, so we have to shift the way we deal with those, and we have to shift. I mean, the industry had to shift production to make things happen properly. Now, again, to our 26 babies, when we look at the type A PDAs, these are the numbers in general. But let's see the type C what we used. Okay, so this is ADO1, which is the old-fashioned PDA device, the one that is typically designed for the conical type. Okay, So when we have a PDA, we were able to use the typical device. But when we have type C and type E, those two types of PDAs that are typical for the preemies, we did not use much of this device. We used three different devices. We use this one, and this one is the Piccolo, which is made for the preemies, for the preemie kind of PDA, this one here. Except that we've been also using this one. What's that one? It looks like this one, right? They look similar, except they don't have these large, longer discs on the sides. This is the plug. Okay? It's plug to close vessels. Why do we have to use those? Simply because manufacturer does not manufacture this one at a larger size. Okay? So one more time, we're cheating the system. So if I have a baby with a large PDA, preem baby with tubular cut PDA, and I have to force myself to use this one, but it's not large enough, it's gonna float away into the PA or the artery or to the legs, to the abdomen, which is not good. So again, one more time, it's an unmet need, and still to today, the embassy does not consider to make this one bigger. Okay? So we have to cheat the system to adapt what we can do to the baby. So we have to adapt to the patient. Device protrusion, as I said, is when this is the device here. I will show you on my map. This is the device here, and this is the disc of the device. We can see that this is the aorta. This is the normal diameter of the aorta before the isthmus. It would be here. And this is how much left from the diameter of the vessel of the aorta. So almost 50% or 40% stenosis is caused by this device. So device protrusion is a real problem. One more time here, this is the device, and this is the disc of the device, and see how far up it does go inside the aorta. Okay? So this could be a hemodynamically significant problem. Just Isabel? Good. So according to prematurity, we looked at our babies, our patients, and we've seen and measured this protrusion rate in percent. And then let's see those who have protrusion of 10% or more, or 15% or more, or 20% or more. If you're not a preemie, these are the proportion of potential of measured protrusions, and these are in the preemies. So the smaller you are, and this is all proportional. In other words, we use the proper device for the proper size of the baby, but still these devices are more prone to be protruding inside a baby's vessels compared to non-preemies. So again, is this a perfect match? Is this a perfect device? One more time, no. But we have to go by what we have, and we have to adapt to the best. Yes.
When you're in the cath lab, you adjust it, but then it can move and protrude afterwards, after the procedure, or when you're doing the procedure?
So the technique, it does not move afterwards, but when you position it, it attached to a wire. Once you unscrew the wire or detach the wire, it has some jump, it will reposition itself. Okay? We're not supposed to cause protrusion, but it's a high proportion does happen, just happen. Now, in the previous, the tubular one, this is not the tubular type PDA I showed you here, but in the previous with the tubular one, we are supposed to put the device inside this tube and not on one side. But still, it's not always possible. So, for instance, this is from the literature. This is a piccolo device put in a PDA, but they still had been forced to keep one disc inside the aortic arch. Okay, the isthmus. You can see it here. It protrudes inside the isthmus, and there is some narrowing. Some of this narrowing is, at least in this case, is probably hypoplasia of the isthmus, not necessarily just completely because of the device. Still, what we have to do is to adjust and put a stent You know, the stent is like tunnel, training tunnel, metallic fiber, where you push everything away and you will push the device towards the wall of the vessel, and to make sure that narrowing is no longer narrowing, it's open with this stent. Okay, so this is another adjustment we have to do. One more time, you guys are bringing us problems. Yeah. Well, thank you for elaborating. So one other thing that we this uncovered or we're going to report in our CSNGC is protrusion of the device into the left pulmonary artery. This is an old problem at the same time. It is rare, but does happen. These are three cases, very interesting cases. None of them were previous, for instance, that's fine. But just to say it happens, if it happens in non-preemie, it will happen in the premature in the preemie as well. So this picture is a little bit difficult to understand, but I'll try to explain that to you. Yes.
I have a question. When did you decide to do those lung perfusion scans? Like, was it the gradient in the LPA? Was it dimension? Was it like, just qualitative analysis?
Good. Yeah, thank you. So the question is, how do we recognize that there's a problem with the LPA, right? So because as soon as we finish the CAT, we're going to take the echo and measure if there's any turbulence in the left pulmonary artery. And sometimes we see it. Most of the time it doesn't exist, but sometimes we see it. And we also see the baby and the child at least 1 week later, and then 2 or 3 months later. So in 4 cases, one was much earlier than the series of those 6 cases. At least in this one, there are only 3 cases, which is about 6%, right? So in these cases, we saw this stenosis, left LPA stenosis, early after the intervention. Okay? So this is an example of this case. So this is a catheter from the IVC, right atrium, right ventricle, to the main pulmonary artery. And this is main PA, and this is right PA. Don't ask why, this is how it is. Okay, this is this is NPA and RPA. The wire here goes to the left pulmonary artery. Notice that you don't see any color, any dye in the left pulmonary artery. Why? Because it was compressed by this device here. So what we had to do, we advanced the catheter further down, and we injected the dye, and we can see that now this is the device much clearer here. And now that we injected the dye here, we can see the LPA. So it's not completely obstructed, but there's severe stenosis. We cannot leave this kid like that. So in the future, the left lung will not show well. Okay, and we need 2 lungs as much as we can. So what we had to do, we had to put a stent in this left pulmonary artery, right? So we had to put a stent in the left pulmonary artery in order to make just a natural flow. Good, done with that, except it's not over until it's over. What we know from past study that we did, I think 12 years ago, we published this from CNGC, and we did on serial cases, almost every case we went to the cath lab, it was the PDA, we did lung perfusion scan. So a normal lung perfusion scan to the left is 45% of the total flow and 55% to the right lung. So anytime you have LPA perfusion less than 40% is abnormal. So look here, the number of cases with perfusion of less than 40% is this should be almost zero, but we have a left shift of these blue columns. Why? Because within a few weeks or a few days after the closeout PA, what we notice is that some portion of gates have diminished flow to the right, to the left lung. But when we repeated this a couple months later, the left shift have improved to the right. So there's a potential. If we have decreased perfusion to the left lung, there's potential to improve with time. But when stenosis is important, by the case I just showed you earlier, there's no way. We have to put a stent. So I said anatomy is very important, right? I would like you to look at this one with me. This is the left ventricle, right ventricle. This is the ascending, descending aorta. This is the pulmonary artery. LPA and RPA. Did you follow there? Yeah, sure. There's one more very interesting anatomical feature here. This is the torrent nerve, okay, the navicular nerve. It goes around the PA. And this one is important for the vocal cords. Okay? Surgical news, if the surgeon does not dissect well this nerve, sometimes babies after birth, after surgery, they lose the voice, or that if it's bilateral, it's much more rare, they will collapse their vocal cords. Breathing becomes very difficult. So this is not an unknown complication, except that in the cath lab, we don't cut anything. But imagine you have a device in this PDA. Okay, device has to stretch the PDA, otherwise it floats away. So it's bigger than the PDA. And imagine afterwards you put a stent in the left pulmonary artery. So this acute nerve becomes chained between the device and the stent. Good enough, it doesn't happen every day, but it happened in the case we did not have to show in this series because it was years before that. So the child had unusual voice. Actually, upon extubation, the anesthetist noticed that there's something wrong with the vocal cord. He had so they were afraid, did they injure the vocal cord during intubation? It was not the case because the ENT went down and looked at that. It was just compression, apparently. It was a palsy of the vocal cord. And it recovered afterwards within a few days, good enough and lovely. One of the three cases that I showed you earlier, the recent ones, one of them had some weird voice, but it resolved very quickly. Just to say that if we have equipment, it doesn't mean that it's perfectly fit to what we do. Okay? Now, dynamics of the PA and the preemie, former preemie also counts. And let me explain this to you. Sometimes we see former preemies in our ecolab, in our clinic. Sometimes we see that the PDA is moderate size or large. Sometimes on the same patient, we see that the PDA is really small, tiny. Okay? So we said, okay, let's see him in 6 months and check one more time. And next time they come back, it's no more tiny, it's moderate in size. Why? Because at least in the extreme, in former preemie, the PDA remains dynamic. It's not fibrotic, it doesn't close and stay the same size. What triggers are, if you looking at these cases, at least 6 cases that I remember, is that even when the ductus is small on echo today, whereas it was moderate 6 weeks ago or 6 months ago, we notice that the left chambers are dilated, okay? Which means now it looks small, but hemodynamically, the last weeks or month, it was still significant. So it was curious to see these kids. Sometimes the PA is large, then it's small, then it's moderate, then it's small, moderate. But the LA, LD were dilated still. So these are twins cases that we reported a few years ago. One of them was 14-month-old former preemie girl, had a large tubular PDA. With follow-up echo, the PDA appeared small on occasion through persistent left chamber dilatation. I'm repeating myself, I'm not going to. Okay, true story. True story. It sounds like Trump. True story. Prior to crossing the PA, this is not so. Here's what we see. This is the heart rate, EEG, and this is the normal or the usual descending aorta pressure. Okay? The diastole is low. Why? Because there is a steaming phenomenon in the diastole from the aorta to the PA. So typical large PDA, you can see this is systolic pressure, this is diastolic pressure. So went to the cath lab, we had this initially as soon as we went to the descending aorta, and then while going up to do the injection, we saw the large PDA here, except that I looked at the pressure and the diastolic pressure went up. I said, God, what's going on? Okay. So went up and re-injected, and the PDA was basically closed. You can see the dye here, but nothing is going back to the PA. What should we do? Should we just stop there and send the baby home? Don't know, because we know that this kid's PDA narrows and opens and narrows and opens depending on the week or the month that you see that baby. So we had to wait about 50 minutes, 50 minutes, doing nothing. We don't smoke, so we just waited. Okay. So we waited 50 minutes until the diastolic pressure went down, which meant the PDA is open again, and then we measure the PDA again, and we put the proper device. Okay? And this is the learning lesson. Anytime you have a PDA, especially in the preemie, you start injecting from the descending aorta, because anytime the catheter is here, you might trigger spasm of the PDA and underestimate the measurements. So if it narrows just a little bit, instead of full size of this baby today, you might underestimate how big it is and underestimate the size of the device you have to use. One more time, if you use much smaller device for this kid, maybe I don't know, within 15 minutes, 1 hour, 2 hours, device will resolve. Okay, so this was an eye opener. Luckily, we noticed this, and we did what we had to do with the proper device, no problem. 2 months later, we took the princess and got that, same thing happened. Okay, so we inject, spasm, wait 1 hour, and we did the intervention. Okay, so this is closing arguments or closing statements. It's very important that in the preemies, especially the very young, low birth weight, small gestational age, the problem is not simply when we do the cath around birth, several weeks or a couple months. It is also a problem down the road when the children are 6 months, 7 months, and so forth, because they have different ductus they require different kind of approach, require different kind of devices. Okay? And the problems are not only when we leave the cath lab, complications, although rare, may occur or we become aware of them 1 hour, 2 weeks later if things are not stable. But there's a great deal of experience in closing PAs in the preemies. I would like to read these statements to you from this consensus guidelines for the prevention and management of procedural complications of transcatheter PDA closure with the unplatted piccolo closure and extremely low birth weight infants. Now talk about the piccolo. Don't forget that if the piccolo for this baby is not the proper size, we have to use guard. Okay, so we have to use something bigger that is not made for it, that works well. In any case, so PDA transcatheter closure in the preemie is feasible, safe, and effective alternative to surgical ligation, right? It may be performed with an implant success rate of 97%. 3% may not be able to do it technically. Major complications, the extreme low birth weight issues are relatively infrequent, less than 3%, but may be associated with fatality if not optimally managed. Modified implant technique avoids arterial access. And this is another very important point, especially if we have to do bedside, because it is feasible bedside at the NICU, as well as feasible certainly in the cath lab. The other problem we did not really discuss earlier is arterial access in a preemie is much more a problem than in a full-term baby or grown-up infant, right? Because the problem is when we insert catheter in the arterial femoral artery, the risk of occlusion, thrombosis, spasm, and so forth is high. You only have one, maybe superficial femoral artery, that's not enough. But if we shut down with a clot or spasm or dissection of this one, you might lose a leg. Okay? So at least in these babies, and in any baby anyhow, we can use the femoral venous femoral access. Sometimes the jugular one if we have to. In other words, instead of going from the artery to the aorta to the PDA, we can go from the RVPA to the PDA. And because the PDA in the previous tubular is not conical shape, if you put the device, which is a straight device from one side or the other, is as safe and as feasible. So this is an advantage to go venous instead of arterial. Placement of the entire device within an intraductal position to avoid aortic and pulmonary artery protrusion. Okay, this is what I said earlier. If it's conical, you have to put the device at the waist and it has to stay there. We have no choice but putting it there. While doing so, there's a part of the device in the PA. It's right around left PA. If it's way too big, might cause stenosis of the LPA. If the PDA, the type A, is too short, part of the device might be in the descending aorta. So these two sides of the PDA and the non-creamy type PDA might be a problem. Good enough. It is not a big problem. It doesn't happen very often. When it happens, it's not clinically significant, but it's still something to look at. And that's it. Now, in the creams, because it is conical, it is best suitable to put the device inside this tube of PDA, and this is the best practice. Device embolization or protrusion, and aortic and PA obstruction. We have to look after those problems at the bedside, during the cath lab, as well as afterwards, make sure there's no migration. Now, there's something else to consider. It is technical, but I'm quite sure that you will capture the idea. So, this is the PDA. This is the size of the PDA. Typically, we use a device that is 150% the size of the PDA in order to have good retention, circumferential retention inside the walls of the PDA. Except if I use much larger device compared to the size of the PDA, what will happen, it's not only that the device is shrunk forcefully smaller, as you shrink it smaller, it will elongate. Okay? Just imagine you have a balloon and you squeeze it, it will elongate. Not the same thing. So, in other words, if you want to put a device inside the PDA, tumor PDA, you should not oversize greatly. You just have to be careful and make sure it's not much longer than your anatomy, just to avoid obstruction and extrusion to one side of it. Cardiovascular injury, again, you don't want to perforate the heart, you want to make a lesion of the femoral artery and cause an amputation or ischemia. Residual shunt is somewhat a problem, but usually it doesn't happen. In other words, we put a device, you don't want blood to flow across or against the wall between the device and the PDA. One of the secondary problems, not just the shunt being there, it's also about hemolysis. So anytime you cross these red blood cells very fast against this metallic mesh, there's a risk of hemolysis, which we'd like to avoid. And one more thing in these previes, the kidneys, okay, they are precious and they are more less mature, let's say, than full-term babies. Besides the fact that they receive many other medications, they have so much stresses, hemodynamic stresses. So injecting dye, high volume of dye, could cause, or the contrast could cause nephropathy. Voila, and this is about it. I'm open for questions. Yeah.
Thank you so much, Dr. Dallaire. So, any question from the audience? Oh, we have a question from Dr. Cavalle and then from Leila. Go for it, Leila.
Thank you so much for the talk. What evidence do you have, like using PICL, for example, could improve the long-term outcomes, like BPD or neurodevelopmental outcomes, regardless for non-interventionist?
Good, great question. I think this is not a debate. but we used to be more forward going to closing or indicating even surgical closure of PDAs in the preemies, thinking that we're doing the best. And literature came about and they said, you know what? The more you touch them, the worse they are. Right? But again, we have to consider the risk level of these patients. So, are we operating on high risk babies because they have multiple problems and therefore they are a risk problem? If we listen to Dr. Dallaire, what he said, so if you consider which pool of patients you are increasing the risk of their viability and morbidity and comorbidities, it's a different question. But nowadays, what we do, we listen much more to the neonatologists in terms of indications. We are more like mechanics or technicians in a sort. So we respect more the neurological. At the same time, I think there was a way to please go ahead and let's close and get on with that. And then there was like probably 5, 7 years. Please don't do that. Then they noticed that not doing that, not closing CA is also a problem. So, the gray zone is difficult to do. So what's first we do know? Dr. Kanai. Yeah.
Thank you very much for checking it out. I just want to comment because I have these twins, ex-friends with PDAs that eventually the PDA wasn't closing, okay, sent to the cath lab. Twin number one, yes, the PDA closed, fantastic. Twin number two, same story as your twin. Adrian injects, and there's nothing, right? And he waited, and there was nothing. And so, okay, we move all the catheters, go to the PACU, wait, stay there for 8 hours, right? Listen to the heart before going, there's nothing, echo, there's nothing. And 3 months later, the pediatrician called me that Tiscar, I hear again a continuous murmur exam. So it's just to, to add to what you said is that these PDAs are crazy.
Right. Bring it up, bring it up.
Happy to hear your experience because I have not heard this before. I'm sure people in your in the international world, maybe this is something that is more commonly mentioned, but I have not heard about that.
Yeah, it's not commonly mentioned, that's right, but it does exist. Yeah, it is not like part of the dream reality. It is reality. It happens. So for these two kids, waiting 50 minutes, exactly 50 minutes, well, boom, they opened up. Another kid also about the same thing. It took probably 1 hour. It opened up. Why this one did not open up, I don't know. I ignore it. Again, spasm of the PDA, we don't know what triggers it, but we know it's very easy to trigger and shut it down. I would have potentially tested with prostaglandin. Okay. Now, people think that prostaglandin only works at birth. This is right. But the only is not right. It works at birth, but it's not only at birth. And we've seen there are reports in the past up to 4-6 weeks, we were able to open PDA with prostaglandin. Okay. So these kids, 14-month-old, why would they spasm and then reopen? Okay. It's not because they are muscular, because their PGE receptors are most likely still effective on a muscular layer of these ductus arteriosus. I would have tried it probably.
So it's a very interesting thought. I don't know, maybe the Perseverance missing works next year. It's very interesting. But my last question is related to this particular case. What is the risk of trying to grow with your wire in that is is there any risk or any downside of trying to poke her, or is it going to stand across more?
Yeah, excellent question. Thank you. I have to think. Okay, give me a second. It makes me look like intellectual. So the first thing I would do if I had to take this baby to the cath lab is to inject from the descending aorta way before I got there. Okay, to see the maximum length diameter of the PDA prior to having spasm and prior to have it free open 50%. Okay, so now I have a real clear idea of how big it is. Otherwise, I would do a scan, because in the scan you're not triggering any spasm. you'll have the full diameter of the PDA. I trust the echo, but again, it's a decision of not just diameter, but length at the same time. I would do a scan with proper imaging. And then once getting there to the cath lab, you ask if we can probe it with a wire. I think, yes, we can probe it, okay? Why? Because we can probe even stenotic coronary arteries, okay, with atherosclerosis, with fat lipids and everything, and we don't dissect them that much. Okay? For sure, if you trigger the PDA, let's say we have injected in the DC neuron, the PDA is big like this. There's a risk that once you cross it, it's open. Once you cross the wire, it will spasm. But that's fine. Okay. If it's spasm on the wire, we can advance the catheter, and we have already chosen the device size and put the device right there. Okay. No matter what, I think because this is a muscular spasm, not a narrow fibrotic thing, it should just relax with the.
Thank you.
I guess.
I just have one question for you, because you mentioned some of the issues with contrast and the risk of, organ damage. Nowadays we use less and less NSAIDs in Canada and Tylenol, and my feeling is that more and more we're going to be looking in the next 2 years at some of these interventional procedure for those who have residual shunts. So I'm wondering the place of avoiding even cath and movement of these patients and actually doing under echo guidance. Could that be a possibility one day?
Yeah, echo guidance is very good.
We're buying.
That doesn't work. Okay, that's simple. So I think I would do this procedure in the cath lab. I would do with the echo guidance. If I have doubts, I have the luxury to inject the dye and see well what I'm going to. That's simple. Okay, but people, if you look at, there are excellent centers in the US where they do it bedside. Okay, in the natal care, they also have a small fluoroscopy equipment. So that's representative for everything. And when you see them, it's like operating on, I don't know, it's really tiny. Everything is magnificent. Okay, it's really good. So I would do it under echo guidance with potential to use the angiometry. Yeah.
Any other questions? Daniela, I think, has the last question, and then we'll go to break.
It's just thank you for your presentation. So my question was related to, well, we are in research after all. Is there any pharmaceutical maybe called like a company to the tools that you're using already, the CAD? Is there any research being done on this? Do you acknowledge?
I need to understand the question. So, is there any pharmacy? I think we're talking about device companies, right? Abbott is the big device company for Piccolo. Octratec is the other company. Both are very good. Potential for funding. That's the question.
Right? No, my question is there, besides using these devices, is there any drug or medication that you are like that you're
To
taking
close the PDA, you mean?
Yes, that is not being used as a NICU. Is there anything else that it can be used also with the tool at the cath lab, or it does not? Something new, like that's been under research, let's say.
I don't think so. No, I talk about like antiprostaglandin. I don't think so. I don't know if the thing about. I think the idea of prostaglandin receptors are no longer distant after a certain age is false, at least in the former premise, based on this experience. So I think your question is, if we use in these older kids, 14-month-old, with large PDA, close, open, if we use prostaglandin blockers, right, or inhibitors, would it work? If you give it for 1 year or 2 years, would it promote thrombosis? I mean, thrombosis or fibrosis of the delta? I think it is something to think about. Why not? Yes. Well, I have no clue. I don't think someone is doing that.
Okay. Thank you.
Thank you so much, Dr. Dahdah. So we're gonna have a little break for coffee, and I think there's cannolis that Daniela is telling me. So they're going to be at this table, but I'm going to ask the three speakers to come because I have a little gift. There's two boxes that are sealed, so I'm not going to open them because I don't want you to break them. But this is what's in the gift. It's a little souvenir so that you can bring your tea or your coffee with a souvenir of the NeoCardioLab with you. The box is there for this one. And then I have two other boxes, one for Dr. Dallaire and one for Dr. Cavalle. And then we are going to take a picture with Daniela, the three speakers, and everyone can have beautiful coffee and with the mugs. With the mugs.
You want to open them?
They're closed, these ones. Sorry.
You can hold it.
Okay, let's please Dr. Dahdah.
Do you want me to open it? I can open it.
It's gonna be a
I
snow
didn't open it
here.
because I was worried they would break during transport. So
But you're an expert in this neonatal transport.
were you able to? You were able. Oh.
Voilà. Huh?
100 computer matin.
Souvenir for sure.
Can you?
Oh, yeah.
Thank you.
Thank
Thank you.
Oh, thank you so much. Yeah, thank you. Coffee and cannoli. And for sugar. I'm gonna put the QR code in. Oh, do you want to keep the boxes in case?
Yeah, okay.
Voy a cerrar acá.
Ah,
Okay, stop
Eh,
recording.
Doctor,
Eso you wanted to